Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks everyone for joining today. And so everyone knows we had a CROI update part 1 last week. Our CROI updates part 2 and 3 will be the next 2 weeks, but there was a break in our CROI update schedule. So I'm going to jump in and do my best to cover the perinatal guidelines update, which came out at the very end of January, and which was a pretty major overhaul of these guidelines. I don't have any conflicts. I acknowledge our funders and will do my best to avoid trade and brand names. And for those of you who are newer to HIV care, this is a reminder of where you can find all of the Department of Health and Human Services guidelines, which really are our, I would say, most tried and true go-to guidelines. There are other guidelines out there we look at sometimes, but these are the ones we look at most often. So this is where the guidelines are. If you're not familiar, I would take a look at the site, become familiar. Treatment guidelines for adults, for pediatrics, for reducing perinatal transmission, for treatment during pregnancy. And these guidelines, commonly called the perinatal guidelines, were updated right at the end of January. Again, I think it was a pretty major guidelines overhaul. There was a lot of reorganization. There was a lot of added language. I'm going to go through some of the updates. One thing I'm not going to cover today is a big change to the language around infant feeding, including breastfeeding and chest feeding. There was a really big update and edit, and I would say overhaul to that section in terms of how we think about infant feeding. There was a big meeting about that at CROI, and I'm not going to cover it today because we're going to have a very special guest who helped write that section join us, and she's going to go through the updates and talk about all the thought process that went into it. Judy Levison from Baylor is going to be with us on March 30th, so please make sure to join us for that. So I won't cover that today, but again, it is a big and important update. I'm not going to cover maternal HIV testing because there weren't really any new recommendations. There was some added language and discussion around false positive tests and the algorithm. For time, there were some changes, but we're going to come back to that another day. So going through the document, and if you go to the document, it is a really big document, but a couple tips. One thing David Spock taught me, if you actually download and open up the PDF and scroll through the PDF, then all the changes are highlighted. That's handy. Or if you scroll through and look at the tables, there's a table at the start of each section that summarizes the recommendations. So 2 ways to make a pretty unwieldy document more manageable. Going through the whole thing, one thing that really struck me, there is an added, really significant focus on using gender neutral language, on individualizing decisions around ART and infant feeding and related issues, on shared decision-making, patient autonomy, on acknowledging and recognizing the risk of gender-based violence, the risk of coercion, and I think these are all really important. The guidelines do highlight early on for language that they have made updates, that they are still working on it, that it's an evolution. There are still in the guidelines that use gendered language like mother or maternal, but efforts that I support and am going to try to do in my presentation as well today, and we'll highlight a couple places where I found that challenging. And as a community, I think these are things we should work towards as well. These are some of the topics I'm going to talk about today. Updates on the recommendations around PrEP, on pregnancy counseling and care for persons with HIV of childbearing age or several different couples trying to conceive. And then recommendations for use of ARVs during pregnancy. There were some really major updates, and there's a study I'm going to review that led to some practice changes. So that's what's coming. First, around PrEP, the update to these guidelines really were to align the guidelines more with the PrEP guidelines and re-update so that all foundations agree with what's in the CDC 2021 PrEP guidelines. So example updates, recommendations to discuss PrEP with all sexually active adults and adolescents who don't have HIV. That includes individuals who are pregnant, individuals who are breast or chest feeding. So really all be informed about of PrEP for HIV prevention. Like the CDC guidelines, these guidelines now say offer PrEP to those who request it or have specific indications. And really TFFTC daily is the only approved option with efficacy data for people with receptive vaginal HIV exposure plus safety data during pregnancy. It really is the only option that has both. And like the CDC guidelines, these now say that people who become pregnant while taking daily oral TDF-FTC can continue it if they have ongoing risk for HIV exposure. So if a person taking TDF-FTC daily for PrEP becomes pregnant, there are safety data. I put one reference at the bottom that I won't go through, but a reference for safety data during pregnancy. Of course, we would counsel the person about risks and benefits, but it is reasonable to continue if it's indicated. Now, the discussion around injectable cabotegravir is much more complicated. So injectable long-acting cab, as you know, has been approved for people with vaginal HIV exposure, but the efficacy and safety during pregnancy really are unknown to date. So these guidelines now say that if a person is receiving CAB for PrEP and they become pregnant, really engage in shared decision-making, talk about the pros and cons and the unknowns and the other options, and make the decision together. Some of the considerations and discussion points: CAB obviously has a very long half-life. It remains in the system for months or even years. So the benefit of stopping it when pregnant really is uncertain. It's going to be in a person's system throughout the pregnancy, even if stopped early on. And what happened in all the clinical trials of CAB for PrEP is if a person became pregnant, it was stopped. So we have some pharmacokinetic data showing the decline of levels throughout the pregnancy, and they seem to be similar than the decline levels for a person who is not pregnant. We also have some of that data from the cabotegravir treatment trials. Again, in the treatment trials, if a person became pregnant, the drug was stopped. What we don't have is any data to date of use of CAB throughout pregnancy. Efficacy or optimal intervals of dosing throughout pregnancy just remain unknown. So there are a lot of uncertainties. Now, cabotegravir does have structural similarities to other ARVs that are safe in pregnancy, like dolutegravir. But again, we need data, and I think we will get it in the future. So these are points that we would talk about with a person if they became pregnant while receiving CAB, and would help individualize the decision of whether to continue or stop it. These guidelines do say if it's stopped during pregnancy and HIV risk is ongoing, it's best to offer alternatives. And for example, if risk were ongoing and from, for example, condomless sex, then TDF-FTC daily would be the recommended option. Now, I was just curious, so I looked in the HPTN 084 publication. That was the long-acting injectable cabotegravir for cisgender women in sub-Saharan Africa, and there were 29 pregnancies with CAB. Again, when pregnancy was identified, CAB was stopped. There were 13 live births with cabotegravir exposure and no congenital abnormalities. So that is some reassuring data, but a very small number, and we need more, and hopefully we'll get more in the future to help inform that discussion. But for now, this key take-home point: oral TDF-FTC daily still is the preferred PrEP option during conception and pregnancy. It is the PrEP option with robust data for safety and efficacy during pregnancy, and approval for individuals whose HIV risk factor is receptive vaginal sex. So the data and recommendations around this may evolve in the future. But for now, those are the updates in these guidelines on PrEP, pregnancy counseling for persons of childbearing age who have HIV. So a couple reminders: one is integrating family planning conversations about conception plans and desires, or contraception desires, into routine visits, and bringing that up on an ongoing basis, because goals do change, life does change. A reminder that there are some ARV contraception interactions, and there are tables in these guidelines that help to review those interactions, especially with the boosters and the NNRTIs. A reminder in these guidelines to counsel about the importance of ART adherence if a person is with HIV is interested in becoming pregnant. And they have this language now, which I've paraphrased, but I think is important. When fully suppressive ART is started before pregnancy and undetectable viral load is maintained, there is no risk of HIV transmission to the infant. I was glad they worded it like that. I mean, really, that is strong wording, and I think appropriate wording. And that is something we can counsel patients about. They've added language and a recommendation to encourage individuals to disclose their HIV status to their partner or co-parent before pregnancy if it is safe, but also acknowledging that that is not always safe and that disclosure should not be required for assisting with conception. And they've added language around considering pregnancy-specific challenges to ART adherence, which may be related to nausea and vomiting during pregnancy, drug interactions with antacids. It may be related to basic socioeconomic needs, housing instability, or again, the HIV status disclosure issues or food insecurity. So really bringing those up and discussing and doing our best to address them early is emphasized in these guidelines. They've also updated the section on reproductive options for serodifferent couples, so a couple in whom the HIV status is different. One is seropositive, one is seronegative. And what they recommend is discussing reproductive options, and this has come up on ECHO, it came up on a case recently, and they now state that the HIV status of one or both parents should not be reason to withhold standard of care infertility treatment. I think it's absolutely true. And when people have different HIV status, condomless sex allows conception without transmission if the person with HIV sustains a suppressed viral load with ART. So really, what I would say is they've added emphasis in this section about U equals U, about the power of maintaining a suppressed viral load on ART, and really supporting conception without PrEP if the couple is comfortable with it. However, they also go on to say that when partners with different HIV status attempt conception, the partner without HIV can choose to take PrEP if the partner with HIV has achieved a suppressed viral load. So really for the partner without HIV, it's a choice. If it adds security, if it adds comfort, if there are other reasons why PrEP might be indicated, it is absolutely appropriate to prescribe it, but may not be necessary. And again, is an individualized discussion. So then let's talk about ART for conception or pregnancy. And I'll go through a few scenarios, and then there's one study I'm going to review. So the scenario, so a person of potential childbearing age desires conception. So when possible, initiate or change the ART regimen with sufficient time to achieve viral load suppression before attempting to conceive. And the ART choices for conception will be similar to for pregnant persons with HIV, and we'll review those in a minute. If a person is pregnant and they're ART naive, then the optimal would be to start a 3-drug ART regimen with one of the preferred regimens that I'll show you. Draw a genotype, but do not need to wait for result before starting ART if the person is ready. So this would not be a scenario where we'd be reaching for 2-drug options. We'd really be trying to go for 3-drug preferred options. And if a person is pregnant and ART experienced, the guidelines update has added emphasis on all of the things that are important to review in order to make the optimal decision about the ART regimen. So ART history, viral load resistance history, all the data for safety of their current ART during pregnancy, and the changes in drug levels predicted during pregnancy, tolerability, drug interactions, disclosure of HIV status and risk of gender-based violence, preference, and comfort with unknowns of some of the medications. The guidelines also make this statement that for most people with HIV who become pregnant, who are tolerating their ART and have a suppressed viral load, their regimen should be continued. They discuss some of the risks of changing a regimen, and we know there are risks. With every new regimen, there might be unexpected tolerability or confusion with pickup or pharmacy or anything, things do happen. So always weighing the pros and cons of making a switch to any ART if a person becomes pregnant. And we'll get more into situations where we might push for a switch versus continue. Here's my summary of the updated recommendations for ART options during pregnancy. On the far left, the category, and then let's talk first about the preferred options. So for the NRTIs, the preferred options are still TAF or TDF combined with FTC or 3TC. So this has not changed, or a Bacavir 3TC if a person is B5701 negative. I think realistically, I would opt for TAF or TDF over a Bacavir 3TC just is hard to tolerate even if someone is B5701 negative and has other potential downsides. So I think realistically, most of us would favor TAF or TDF, but a Bacavir 3TC is still listed as a preferred option. We'll get into some reasons we might prefer TAF in pregnancy, but that's an area where we need more data. Now, the one preferred integrase inhibitor is dolutegravir. A shift here is that raltegravir was moved to alternative. In the last iteration of the guidelines, it was another preferred. And then the one preferred boosted PI is boosted darunavir, with a reminder that it needs to be BID during pregnancy due to reduced levels, especially late in pregnancy. Atazanavir ritonavir was moved to alternative. So the two major shifts in these guidelines were moving raltegravir to alternative and moving atazanavir ritonavir to alternative. And these guidelines really emphasize that our two go-to options during pregnancy are dolutegravir or boosted darunavir. And I would argue that for many reasons, dolutegravir is going to be the go-to in the majority of instances. Now, bictegravir and doravirine are still listed as having insufficient data. At the bottom, efavirenz or rilpivirine are both NRTIs that are listed as alternative options. I want to emphasize that the cobicistat boosted options are not recommended because of decreased drug levels late in pregnancy and data for virologic failure late in pregnancy. So the cobicistat boosters are not recommended because of that issue. Cabotegravir rilpivirine is not recommended because of insufficient data. So it's not because of toxicity, it's not because of data for virologic failures during pregnancy, it's just a total lack of data during pregnancy. So we'll get more into some considerations if a person becomes pregnant while taking these specific options. So I think you all know this, I won't belabor it, but there was for a period some concern that dolutegravir might increase the risk of neural tube defects as compared to other ARV options, and that has not borne out, and there is now solid data that the risk of neural tube defects with dolutegravir is not higher than with other ARV options. So dolutegravir is preferred for conception or for any trimester of pregnancy, including first trimester. The TAF versus TDF discussion for pregnancy is ongoing and controversial. We know, and I'll show you where this data comes from, that when combined with dolutegravir, the efficacy and tolerability of TAF FTC and TDF FTC are similar, but TAF FTC seems to be associated with fewer adverse birth outcomes and with a lower risk of insufficient weight gain during pregnancy. Now that's the wording from the guidelines, and it's confusing wording. Basically, TAF may lead to better, healthier weight gain as compared to TDF during pregnancy. Well, I'll show you where that comes from. And then there were in the past potential concerns raised about fetal bone and early life bone growth abnormalities with TDF, but so far, studies that have done DEXA scans on infants who were exposed to TDF have been reassuring and have not found that to be true. But really, this is an area of ongoing controversy. I do want to take a minute and review this study before we talk about specific scenarios again, because I think this really did affect the guidelines in terms of the emphasis on dolutegravir being first line for pregnancy and the discussion of potential benefits of TAF. So this study, which first was presented back at CROI 2020, and we talked about on ECHO at that point, was published in Lancet in 2021, led by Shaheen Lachman and colleagues. So this was done in 9 countries, including the US. The other countries were in Africa and Asia. It was randomized, open label, and enrolled ART-naive pregnant adults who were at 14 to 28 weeks gestation. And participants were randomized to dolutegravir with TAF FTC, dolutegravir with TDF FTC, or efavirenz TDF FTC. And this is the viral load suppression at delivery based on a viral load below 200 copies, comparing the two dolutegravir options. That's the blue bar. That's dolutegravir with TAF FTC or dolutegravir TDF FTC combined in the blue bar, compared to efavirenz TDF FTC. And the dolutegravir-based options were statistically superior at achieving viral load suppression at delivery and at time to viral load suppression. When comparing the two dolutegravir groups, dolutegravir TAF FTC versus dolutegravir TDF FTC, there was no difference in the virologic outcomes. One thing I would add, if you look at the paper and look at the proportion with viral load below 50, the difference here becomes really striking. The difference is the blue bar would be 95% and the green bar would be 85%. It goes way down, or maybe even 80%. It was really striking, the difference in those who achieved a viral load below 50 at delivery, but their primary outcome was viral load below 200, which is what we think about as being our major threshold for reducing the risk of transmission. But then the other thing that came out of this was that looking at the 3 different study groups and looking at adverse pregnancy outcomes, it appeared that there was benefit to TAF over the 2 other NRTI backbone options, both of which were TDF-FTC. So adverse pregnancy outcomes were significantly less frequent with dolutegravir/TAF-FTC than with the other two options, and preterm delivery and neonatal death were significantly less frequent with dolutegravir/TAF-FTC than with efavirenz TDF-FTC. And here you can see the weight change finding, which got a lot of attention and discussion, but no one really knows exactly what to make of. You can see in the blue the average weekly weight gain in kilograms with TAF versus TDF versus efavirenz, and the blue with TAF is actually the closest to what's recommended and the healthiest. So remember that there's a difference in how much weight a person gains if they take TAF versus if they take TDF, but it seems like the main reason for that is that TDF suppresses weight and has some degree of mitochondrial or other toxicity that suppresses weight gain. So some would say that this is evidence that TAF is better and is healthier, but I really think the jury is out and we need more data. And this, frankly, as an aside, is one place where I struggled with how to use non-gendered language. So the study used maternal weight gain, and I struggled to come up with another term for maternal. So would love to learn from the community if you have a term you use besides maternal. I looked up and there were recommendations to use person giving birth or birth giver, but that's one place where I struggled to use non-gendered language. So if you have suggestions for what you use, please let me know. Would love to learn. So then let's come back to these scenarios, because I think this is what really comes up in clinical practice. So what to do if you are seeing a person in clinic who is pregnant and you are thinking about their ART and counseling whether to continue or switch it. So let's start with the easiest scenario. A person is pregnant and they're taking one of the preferred 3-drug ART options, like dolutegravir with 2 NRTIs. They're tolerating it, their viral load is suppressed. I think it makes sense to continue. If a person is taking one of the alternative options, so let's say rilpivirine TAF-FTC or rilpivirine TDF-FTC, and they're tolerating it well, their viral load is suppressed, then the recommendation is to counsel, talk about options. It's reasonable to switch to a preferred option, or it's reasonable to continue. If a person is taking a regimen that clearly is not recommended for pregnancy due to toxicity or due to poor efficacy, these older drugs, which really no one should be taking anymore, then it's really clear, should definitely switch. And if a person's taking any regimen and their viral load is above 200, then we should be getting genotypes, getting resistance tests, and switching based on resistance results. But then let's turn to what I think are the more challenging clinical situations. So what if a person is in your clinic and they're pregnant and they're tolerating their ART and their viral load is suppressed, but they're taking a regimen that does not fall into the preferred or alternative category? So let's take a common one, a 3-drug regimen that has insufficient data, BIC/TAF-FTC or doravirine with 2 NRTIs. These guidelines, again, added much more emphasis on shared decision-making, on counseling about options, and on individualizing these decisions. And really, in all of these scenarios, either switching the regimen to a preferred or alternative option, or continuing the regimen with careful viral load monitoring, which they defined as every 1 to 2 months. So for example, with a regimen with insufficient data, BIC/TAF-FTC or doravirine, counsel, reasonable to continue, monitor viral load every 1 to 2 months, or switch. With the cobicistat, whether it's elbitergovir/Cobi or darunavir/Cobi or azanavir/Cobi, they say similar, though I would say that in my personal opinion, this is a situation where I would probably be more on the side of encouraging a switch, because this is a situation where there are data, there are studies showing that with these options, like the boosted elbitergovir options, during the 2nd and 3rd trimesters, there can be virologic failures, there can be virologic rebound, and especially late in pregnancy, that could increase the risk of not only transmission to the fetus, but then needing to get genotypes, if resistance has developed, switching late in pregnancy to a more complex salvage regimen. So while the guidelines give room for shared decision-making here, this is one situation where personally continuing a Cobi booster, especially late in pregnancy, makes me nervous, and I'd be curious what others think, but that's one place where I would be more on the side of trying to encourage a switch to a preferred option. If someone is pregnant and doing well on a 2-drug regimen, dolutegravir 3TC or dolutegravir rilpivirine, there are safety data for each of those drugs during pregnancy, there just aren't efficacy data for 2-drug therapy during pregnancy. So that's another situation where shared decision-making would be appropriate, and it would be reasonable to either switch the regimen during the pregnancy and then counsel that after delivery, a person can switch back, or continue the regimen with frequent viral load monitoring. And then if someone is receiving IM cabopivirine every 1 or 2 months, there really are a lot of unknowns around this. Again, there is very, very limited data in the clinical trials. It was not continued when a person became pregnant. So what's recommended is to counsel about the insufficient safety and efficacy data. Again, make a decision with the person about either continuing it with frequent viral load monitoring or switching to oral ART during pregnancy. And there really is no right answer. If a person develops acute HIV during pregnancy, and actually these guidelines, they define it as, or they describe it as early HIV, acute or recent, meaning within the past 6 months. The point they're getting at is these are situations with very high viral loads in pregnancy and therefore a high risk of transmission to the fetus. Then they make the point that we should be obtaining genotypes and then starting a preferred empiric regimen, usually with dolutegravir. However, and this aligns these guidelines with the PrEP guidelines and the adult treatment guidelines, if a person has any history of injectable cabotegravir PrEP exposure, then at baseline, we should be adding integrase genotypes and we should be using boosted darunavir as our empiric option until we get resistance testing back, not using an integrase inhibitor, giving the risk of integrase resistance. And they emphasize this really in the section on early HIV, acute or recent, but I would argue, and this is my speaker note at the bottom, that these recommendations could apply with anyone newly diagnosed with HIV during pregnancy, especially late in pregnancy. Draw the genotypes if they have a history of CAB for PrEP, add an integrase, and then if they are willing to take ART, start ART. There's no reason to delay. There's no reason to wait for the genotype results. If they've not had CAB for PrEP, dolutegravir 2 NRTIs is the best option, achieves viral load suppression the fastest. If they do have a history of CAB or any reason to suspect integrase resistance, then boosted darunavir is the recommended option, with a reminder that boosted darunavir should be dosed BID for pregnancy, requires food, and there are data that PIs may increase the risk of preterm birth. So the key takeaway point here is that really the best option for pregnancy nowadays seems to be dolutegravir with TAF or TDF and FTC3TC, and is generally preferred. And there may be exceptions. And again, there are a lot of situations in which we should be individualizing the decision. Finally, the last couple sections, and we'll wrap up here in a minute or two, the last couple sections that were updated with the recommended HIV lab monitoring. What I wanted to emphasize is that during pregnancy, the emphasis is on checking at least every 3 months, and then again, near delivery to inform delivery, whether C-section is indicated, and the prophylaxis during delivery, which I will mention. And these guidelines have also updated their definition of virologic failure and when to get resistance testing to be in line with the adult treatment guidelines, and to say that if a viral load is above 200, then we should be considering genotypes. They also acknowledge that in that 200 to 500 range, the lab may not be successful with it, but this really is the definition of virologic failure in which we should be trying to get resistance testing. There's new language on amniocentesis, which is much more supportive of doing it if a person has a suppressed viral load on ART. And the intrapartum care with HIV, we just haven't talked about in a while, but there were no changes. Just a reminder that if a person's viral load is above 1,000 copies, or it is unknown at the time of delivery, or there are suspected missed doses since the last viral load check, then the person should get IV AZT during delivery and C-section scheduled at 38 weeks if there is time to do that. So really what I want to emphasize here before wrapping up is that adherence support and viral load monitoring during pregnancy are really critical, both for the health and care of pregnant persons with HIV and for eliminating the risk of transmission. Final reminders, as we've learned here on ECHO over the years, develop a delivery plan early so that all on the team who will be involved in the delivery know. We've seen the power of that here with folks doing that here in our ECHO community. The Antiretroviral Pregnancy Registry is how we learn about ARVs and learn that they are safe in pregnancy. So if you're seeing someone who's pregnant, log on there, put what ARVs they are on. It's pretty easy to do and you'll get some follow-up, but that really is how we learn. and it's easy and important. And then please join us March 30th to learn about the updates to the discussion on infant feeding. And thanks, everyone.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.